And now I'm going to introduce our speaker, reintroduced from last week. Dr. Fabiola Arbelo Cruz is an attending addiction psychiatrist at the Connecticut Mental Health Center in New Haven, Connecticut, and an assistant professor of psychiatry at Yale School of Medicine. One of her roles at CMHC includes working with the street psychiatry team, a model of mental health and addiction care delivery that takes physicians and other providers to the streets to provide care primarily to people who are experiencing unsheltered homelessness. Dr. Arbelo Cruz received her medical degree from Ponce Health Sciences University School of Medicine in Puerto Rico. She trained in the general adult psychiatry at Boston University and Boston Medical Center, then completed the addiction psychiatry fellowship at Yale. Dr. Arbelo Cruz is the past recipient of the APA Travel Scholarship for Minority Medical Students and the Externship in Addiction Psychiatry Award, a AAAP John Renner Award, and Boston University Medical Center Chairman's Award. She was accepted to the Yale Reach Scholar Program, a program that's aimed to adequately train physicians to work with minority patients with co-occurring mental health and substance use disorders. Her academic interests include racial inequities and substance use treatment in Latinx communities, stigma of addictive disorders and their treatment, and medical education. So again, we welcome back Dr. Arbelo Cruz, and again, thank you so much for being with us today. I'm going to just briefly go over Dr. Arbelo Cruz. There's no financial disclosure, and share the quick. I'll pass over to just Dr. Arbelo Cruz now to share the practice gaps, lessons learned, and a quick overview from last week before we dive into our questions for today.
Thank you so much. Good morning, everyone, and happy to be back in this space. Thank you for having me and for making a priority this topic. So just to put everyone in perspective, the practice gap that were identified by me for this presentation was that, first, explanations for the variation in addiction treatment outcomes in minoritized communities for a long time, and still happens today, focused on biological differences without considering how other aspects as social factors, including racism, contribute to differences in treatment outcomes. So that's one. Second, being aware that cultural responsive services are crucial to addressing disparities in minoritized communities, and can be in the form of how people access treatment, how people perceive treatment, and are retaining treatment. Next slide, please. And my hope last week with the presentation was threefold. Pretty much the first one, to provide kind of brief overview of examples of inequities in the treatment of substance use disorder, provide an overview of drug policies that have influenced how we see and, in a way, manage substance use disorders. And thirdly, providing strategies on how to assess and treat equitably addiction disorders in minoritized communities. And the ultimate hope was to just for everyone to get more knowledge and understanding of what are racial inequities in addiction and how did we get to have inequities. I just want to remind folks that there's a difference between disparities and inequities. When we talk about disparities, we're just talking about differences in health outcomes. When we speak about inequities, we're also not only referring to differences in outcome, but acknowledging where they're coming from. And second, expected outcome was to just be able to list key elements of equitable addiction treatment. And with that, I would like to share some slides. So if I can get permission to share some slides, I will just go over 9 or less slides about last week's presentation, just to provide a refresher. I would like to see thumbs up if you're able to see one slide. Thank you. So last week, we started talking about the U.S. health composition, U.S. population composition, which more than half of the population are white communities And when we think about minoritized communities, talking about Latinx, Blacks, Native communities, the proportion is quite low. But when we look at overdose deaths and other outcomes, we see that the proportion of increase of terrible outcomes is disproportionately in marginalized communities. And when we think about addictions and treatment, every community, everyone, white, Latinx, Black, Native communities, they have low rates of treatment, can be access, completion, retention. So that's in every single group. And I also provided some details about how for specific groups, like for example, Black and Latinx, when you look at treatment completion and you control for some variables like socioeconomic factors, the completion disparity compared to whites narrowed down. And when we think about that, it just suggests that like the differences for completing treatment was mainly explained by social factors. So what is happening that people don't access or have issues getting addiction treatment? It's multifactorial. We just spoke about three big categories: attitudinal barriers that can be from the patient perspective, to the provider's perspective, to the family member's perspective, to policy members' perspective. In terms of social structural barriers, we're talking about stigma, direct discrimination from employer or from even providers, even the own patient discriminated against self. We talk about also policies that make it difficult for people to get treatment. In addition to social barriers like transportation, social support, competing needs. Some folks might want to prioritize work to get money, and they might miss an appointment. And thirdly, cultural barriers, that treatment not being in the language that is preferred, or there has been data that suggests, particularly for Latinx folks, that when they look at treatment, sometimes they perceive that treatment might not be efficacious if the person that is treating them do not understand the cultural background and experience, just to provide examples. And thinking about vulnerability of addictions, and these factors are applicable for any racial and ethnic group in the US, but unfortunately more so for marginalized communities. When we think about vulnerabilities to addiction, I invite you to thinking about structural determinants of addictions. We know, and there's data that suggests that the physical environment, the economic environment that someone grew up with does impact the vulnerability for development of addictions, and determines if one can get treatment quite easily or not. Some people need to drive far away. And when we think about racism as a phenomenon that affects racial and ethnic minoritized group, unfortunately, for many, many years, systems of care, consciously or unconsciously, have affected our folks in multiple ways. I provided treatment examples like residential segregations, how in US, and this could be for Native community, Black communities, racial segregation led to disenfranchisement of communities of color, making people have less market accessible, less hospital accessible, less clinic accessible. And the impacts of it are still seen today. Even though there are not specific laws that promote racial segregation, we still see the impact. There are many areas that do not have much therapists, does not have many psychiatrists. And again, all that together, along with the war on drugs that unfortunately led to mass incarceration of Black and Latinx specifically, led to like generational vulnerability for poverty, for lack of opportunity, lack of employment, and put the person and their family member in disadvantagement long term, making it risk factor for many health outcomes, including addiction. So when we look at social, cultural, economic, physical environments, even data despair, access to healthcare, housing, trauma, looking at in a lens of how racism and not race has impacted health outcome helps understand how marginalized communities have almost made vulnerable to disease and conditions, including addiction. And I provided this slide just as a reminder, mainly to the right, to the figure of how racism, along with other root causes, has led to power imbalances, wealth imbalances across many, many systems that governs our daily life, that in turn leads to imbalances and vulnerability in social determinants of health in many ways as listed there, which in turn led to psychosocial stress and unhealthy behavior. And I think it's important to contextualize how we view addiction in the way of how US drug policy has evolved. And I just want to mention that one key feature that we have heard a lot and we're going to keep hearing about is the war on drugs, which pretty much the beginning was in the 1970s with the Comprehensive Drug Abuse and Control Act. And pretty much it's not only drug policy, but what was happening around drug policy, around those times when you see social media, when you see the news, literature, one could clearly see how addiction was viewed, was put as a moral failure. And that has contributed a lot to how addiction has been stigmatized, how it is viewed by people, including us and patients, and how do we go by treating it? Because even reimbursement rates in terms of insurance for addiction treatment and behavioral health, there's quite a lot of differences when we see it with medical conditions. But there has been many US drug policies that have affected vulnerable communities. And I will say that it's not my words, but people that I admire a lot. I have often heard, perhaps you all know as well, that the war on drugs is more a war on people. Even the Harrison Narcotic Act in 1914, there was also some racial targeting when they were trying to regulate coca and opium, Chinese communities, for example. So these same people that have mentioned like war on drugs is more war on people, they have also reflected on the following. As an example, if COVID-19 would have mainly affected marginalized communities, we will have the same response that we did in the last 4 or 5 years. And I think it was a very interesting, reflective question from the folks that I have learned a lot from. I also provided some evidence of how marginalized communities have been disproportionately affected in terms of substance use, mainly in terms of incarceration, and also immigrants, Black immigrants, many of whom identify as Latine as well. Not only they have been incarcerated at disproportionate rate, but also just because of having a substance use disorder, they have more vulnerabilities to being detained and deported. And again, this kind of thing does not happen with other medical conditions or behavioral health conditions as much. So what can we do to address inequities in marginalized communities? There's no one-way solution. It requires a multi-level response. And as a reminder, there are key elements of equitable treatment. It needs to be readily available it must attend multiple needs, not just the addiction, thinking about the social factors. It should be of adequate duration. We need to be more intentional and letting folks know from the beginning, or asking the question, how long do you think you need to be in treatment? Just to plant the seed and have an opportunity to educate. And lastly, addiction treatment should include medications if the person wants, and culturally informed counselings and therapies. Almost ending on my review, when we're thinking about culturally responsive interventions, scholars have summarized those interventions in three main focus. One, incorporating cultural values. That could mean just having clinicians or staff members that are from the specific group, having resources in a specific language that will be quite easy to understand and read. Second, culturally adapting evidence-based interventions. The example that I provided is that CBT for CBT, which is a computer-based CBT intervention. There have been folks that have been able to adapt that evidence-based intervention to be suitable and adapted to specific Hispanic communities. So it means adapting evidence-based intervention to a specific cultural group or racial ethnic group. And lastly, cultural responsive intervention can be implementing novel strategies. And when we talk about implementing novel strategies, it really involves engaging with the community in the development of the intervention, in the implementation of the intervention, and evaluation of the intervention as every step of the way. And we spoke about specific example like the Imani Breakthrough Project that is an example of a novel strategies tailored to cultural norms. But the most important thing about this slide is that one intervention would not work for all racial ethnic groups. So culture is not dynamic, sorry, it's not static, it's dynamic, it changes a lot. So a specific cultural intervention for Latinx might not be suitable for Black communities or Native communities. So cultural intervention will be specific on where they're going to be delivered, the population they're being targeted, and the intervention goals. And with that summary, I know Chris will bring up more slides to start a Q&A.
Yes, thank you so much for your refresher. And I hope that that brings up additional questions. So again, for people that, if that prompted any questions, feel free to go ahead and put those in the chat, and we'll get to those after the questions that we already had submitted from last week.
So the first question that I see here is, how does the street program model safety process or structure when going to the client? So I'm sensing that this question goes to how we go about making sure that we're safe in the streets, and what structure we have to do that. So I work in institute psychiatry, and I think the main thing that we tell every staff member and trainee is no heroes policies. And I can give you an example. We were doing a outreach intervention in Fairhaven area in New Haven, and we were nearby a harm reduction group, and suddenly, unfortunately, there was a shooting. And the first thing that we did, knowing about safety, is like we were able to see the person who was being targeted, but we got inside our vehicle, meaning like we know that as doctor we have the knowledge to help someone, but safety first for us, and that applies for everything else. So we just got in the vehicle and called 911. Similar instances when a patient might be arguing with another person, and let's say someone threatens to punch someone, we say something on the lines, we don't feel comfortable what is happening right now, we're just going to remove ourselves. So safety first, no heroes policies. Other things that we do are that we never go to encampments alone. We go in pairs. If I don't have someone like my partner to go to do outreach, I narrow my outreach to community centers, meaning the library, the public library, or soup kitchens of the city. So it might be that I do less in one afternoon, but safety first, and I will not go alone to an encampment, even if I know the encampment very well and the people there well, just for safety that we know we have. We don't wake up folks. We go to many places and they might be sleeping. We just don't wake them up. If someone from our team feels uncomfortable or they have a negative gut feeling, we all leave. It's important that every member of the team feels comfortable and safe. So at least those are the main things that I can see we do to make sure that we keep ourselves safe. We trust also our patients and the people that work with us. If a patient tells us, you know what, today is not a good day, please return another time, we respect that. If we want to engage in a specific place and it happens that someone is in front of that place and they just not know, we respect that, we leave. We're going to their homes and we respect that. Just quickly, before I jump to the second question, I know someone asked for me to elaborate on dynamic versus static, and I appreciate that clarification. So when I was talking about culture earlier, I shared that culture is not static, it is dynamic. Culture involves many aspects of one group. It could be from language to the spiritual part to traditions. How we see the people that are nearby us is rich. It involves many, many, many aspects. But we know that it changes. Culture changes. For example, I am Puerto Rican. I was born in Puerto Rico. I grew up there. I did bachelor's. I did medical school, and I moved to mainland US in 2017. I have changed a lot. I have acculturated, and acculturation is a way of someone changes like their cultural identity. So another way I see it in a bigger picture, in terms of Latinas in the US, we kind of group Latinas or Latinx or Latinos in first generation, like they were born outside of the US and came to the US, to second generation, their kids, third generation, fourth generation, fifth generation. We know that different generations kind of have different grasps of the cultural identity. And even some aspects of a specific group's culture, for example, in Latinx, we talk about a lot familism, personalism, spirituality. Those things might be more relevant and important for first generation Latinos and Latinas and second generation, but might be, for example, less relevant to a fifth generation or sixth generation Latina. So that's what I mean. Culture is dynamic, not static. Thank you for the clarification. Okay, moving along. Another question is, triaging is so important. Can you talk more on the triage process of the street program described near the end of the discussion last week? Absolutely. We get many referrals. We not have made everyone, right? Because we are a small team, but we refer people. So let's talk about how it works. We have only one lead clinician, and the only clinician, because we have two MDs and a clinician and a program manager, and she's the point person. She received referral from clinics, from community centers like the soup kitchens or a case manager. And they tell us a little bit about what's going on. Like, this person has addiction, but there's something not right. I think they're talking to themselves, something is not right. So usually they will tell us where to find them. If they don't tell us, we kind of ask, like, where do you saw them? Where do you usually frequent? So we can keep an eye in specific places. Once we see them, we just have a conversation if they let us. It might be that we see the person and they just don't want to talk that day. Often that happens, and we just ask, would it be okay if we come next week? They usually say yes. So when we see them, we just kind of get a sense of who they are and may share like, hey, they told us that it will be good for us to speak. We were wondering what's going on in this area. And depending on what they tell us and what we see in terms of symptomatology, we might have recommendations. It can be that we refer them to a specific place, but they might not want to be referred. We might get a better sense of what the psychiatric or behavioral health issue is, and we can relate back. Many times it's just providing an explanation of what's happening to a specific person, because not everyone in the community has psychiatric training or social work training or psychology training, right? So I would say that most of the cases that are referred to us, we refer to the clinics that we work with because we want to just limit our caseload to unsheltered folks, people who have severe mental illness, and there's such level of complexity that they will not get to the clinic. So we like to think of ourselves as a bridge from the streets to the clinic. We don't want to take people from the clinic to the streets. So at the community level, partnership with local organizations and leaders are critical to increase trust and decrease stigma against substance use disorder treatment. Do you have knowledge of any organization that would be good to approach and work with to address stigma, particularly within racial minority communities? Definitely. Like the first big organization that I will recommend is, I will drop the link because I have the link here for you guys. It's the Opioid Response Network. And the reason why I really like them is because you can send requests to them, and they already have a network of providers that are quite knowledgeable what's happening in the US, and they can provide training. They already have in their website case studies, for example, about managing SUD in Black gay males and HIV, or how to engage with faith-based community organizations and liaison for addiction treatment. So in terms of macro, that will be my way to go. In terms of community, my first thought is you need to know your community, and you need to know who are leaders in the community and who else is working in the community. Like in our work here, we invite people from different clinics just to share their expertise of what they have been doing, what they have been seeing, what's working. I have the blessing of being a research physician for the Imani Breakthrough Project, mainly the churches that primarily have Hispanic participants. So I have seen how, for example, the PIs of the Imani Breakthrough have truly worked in creating relationships with community leaders at churches for years, not something of 3 months or 2 months, to a point that they have buy-in to talk about addiction treatments and them wanting to have their people also get novel approaches of interventions. So in summary, in terms of one key place that I will start if you want additional training, I think that the Opioid Response Network is a key thing. I use it, and I know colleagues advertises as well. In terms of second, you need to know your community, and even in every agency, I try to have a sense of who's my point person if I want to know more. For example, here I'm in New Haven. There are different clinics like the App Foundation that does methadone treatment, Corner Scott Hill, which is a FQHC. There's Connecticut Mental Health Center where I am. There's Fair Haven Clinic, right? And I think each of those organizations, they have their unique kind of set of patient population. And when we have meetings, we get the expertise of everyone. And if we want to do a specific approach, let's say, for example, Xylazine test strips. Xylazine is an anesthetic, like it has been used historically for horse anesthesia, but in some areas like Philadelphia and here in Connecticut, we're seeing more mixed with fentanyl, fortunately. So when thinking about how we go about letting our people know, our patients, and having harm reduction tools like xylazine test strips, we partner with leaders and they help to pass the word to the patients and the tools. So I think that learning for your community and knowing the leaders is crucial for that, because the leaders do help with influencing the people that are nearby them, and then that helps influence the patient's percept. It's not as easy, right? It can be that where you work, perhaps the leaders nearby have a different approach than you guys, right? So that can be harder, but trying to know who are the person that are leaders in the community and more like-minded, that you're able to gain from them, share knowledge as well. And the last thing that I will say is that, for example, if you're interested in knowing more about like how people do it, right? Like having a question to the Imani Breakthrough PIs, like Dr. Jenna Jordan and Cheryl Bellamy. I know that they have gotten questions about other states, about how to implement the Imani Breakthrough in other sites. I have seen that as well. So reaching out to people that are doing similar works in other states. Definitely. What we're doing now is part of this. I love, well, let me read the question. Sorry, I went ahead. Are there programs you can recommend to help people working in substance use disorder to build more cultural competency skills? I will say again, the Opioid Response Network, if you send a request with a specific cultural competency skill for a specific group, be specific for Latina, for Blacks, for Native communities, people involved in the criminal system, right? Because those communities have their own cultures. They will facilitate training. So that's the first thing that comes to my head. And second, I go again to the community. There are people that are already doing the work, invite them. But that takes knowing your community and knowing who is doing the work with which specific community. So when you ask for this training, it's important to be specific what specific cultural group you want to learn from more. It's very important to be more specific, because again, one cultural skills, cultural responsive care to Latinx might not be fully applicable to Blacks and Native communities. That being said, there's always elements that can be shared. Like, for example, spirituality is very important in Native communities, as well as, I would say, first generation, second generation, third generation Latinas. So again, being specific in which group you want to have more skills, I think is quite important. So many people who are eligible for insurance coverage remain uninsured due to barriers with enrollment process and eligibility policies. What recommendations do you have to help these individuals? Big question, a very important one. So first, when I think about uninsured folks, I divide them into groups. One, as a this question, that can be insured, but they have many barriers to get insurance. And second, there will be the folks that perhaps because being undocumented, they will not be able to have insurance. So they will continue to be uninsured. So the first approach that I take for this is knowing who inside my organization can help me know if they have or don't have insurance, because many times people can have insurance, but they don't know, or they lost the card. So I have someone in my clinic that has access to see if someone has insurance or not. And if they don't have access, what they need, because it might be that they just started the process, but they need to continue some paperwork, right? So it's crucial to know who at your institution can help get information if someone's uninsured or not, and what needs to be done. Second, knowing who outside of your institution can also help with that. Because if you only depend on a plan A, you will be limited. The third thing that I will say is knowing in your community, if there's any, which organization can have programs that people can get medication with a sliding scale. And it's always good to know what sliding scales mean. For example, here, people need to pay $25. And with those $25, they can see the doctor and get the medication. It's covering those $25. Some folks don't have the $25, but just knowing the number helps when you're talking to the patients. So in my case, I know which clinic has a sliding scale. I know which facilities have funding to provide psychiatric medications for free for uninsured people. And I also know, mostly for undocumented folks that do not have insurance, I know in terms of addiction treatment and withdrawal management, which places might have a grant to provide withdrawal management. Because many times, and I bet you see it, there's uninsured folks that go to the ED to get treatment, and they call state facilities and they're all full. So they just discharge a person with any other follow-up. So trying to know, in thinking ahead, what in the community can be used, right? For psychiatric medication, which is different from addiction medication, I know that Walmart has the $4 program, meaning that they have specific medication, not all medications, that for $4 you can get some supply. So it's important to know what can you use. And the last thing that I will say, I think it could be easy to feel overwhelmed if one has not done something for insurance in 1 month. But it helps me to give the expectation quite early to folks, like, listen, I know you don't have insurance. It seems like you also need to work on getting your ID, your birth certificate. This might take weeks and months, but let's first find a person you can work with to get this done. And it will take a lot of time, but let's just connect you with the person. Just making sure that they know and who the person is what to call. I didn't fix the issue, but I'm letting myself and them know what to expect. The next question, one of the biggest barriers we have seen for clients is housing. In addition to general lack of affordable housing, many residential programs or other recovery housing communities do not allow residents to be on medications for opioid use disorder. Is this something you have dealt with where you have worked? And if so, how did you address these issues? So in the setting that I work, I do not experience this as much, but I will give you other example when this comes up. Before I give the other example, I will say that when I have folks that I work with that are looking for a residential, I definitely tell them, make sure you ask if they are okay you being on methadone or Suboxone. And also make sure you have an idea, the people that are there, if they're okay with medications, just so they have a sense. But I think in my work, working with unsheltered folks, it's not with MOUD that I see it the most, it's with shelters. People don't want to go to shelters for the most part. When they do displacement or encampment or when winter comes, they open more shelter beds, and people don't want to go to shelters because there are many rules that is hard for them to keep up, just being in a shelter, like getting at 5 p.m., not being able to get out, and then experiencing withdrawal while they're in the shelter, because many of them need to use at night to not get withdrawal. And what we have done is trying to let the shelter people know, meaning like their leaders, of what we're seeing. Like, I think I shared last week that there was a displacement out of encampment, and they opened even more beds to have those displaced people go to shelter, but we told them they will not go to shelter. It's too rigid for them. There could be more vouchers that would take 6 months or even more to house them, but it's not the best answer. We do have a housing crisis, and we need to do better at it. I will say that in similar situation, what has worked for me and is hard is having someone in power that is like-minded to us or me be able to speak on your behalf to the residential program to see if they can flex some of their rigidity. So when I cannot accomplish something, going to someone that is in a position of power that we have already a good relationship with. But do expect that those changes will not happen fast. It's a month built up of trying to make changes. But listen, if you're able to make just one change, that's progress. But that is a barrier. Many residential programs, I think, have enough more in the US, have these barriers, and many are not. I'm blanking on the word in English, but not all of them are being evaluated consistently in the same way. So it leads to differential experiences in residential programs. There's a problem. It is. Next question. The Imani Breakthrough Project looks impressive. Given its success, have other communities in the US adopted their program? Are there recommended protocols or other resources for agencies that would like to adopt this program, particularly with respect to identifying appropriate churches to involve in the project? So I don't work fully with other states. That being said, the short answer is yes. Other places in the US have adopted their program. To give you an example, I have worked in Hartford, but I know that I have provided trainings on my experience at Hartford to staff members in New Orleans that are following a protocol that was shared with them, but they're not doing it in a church. They are applying the protocols in their clinics. So the answer is yes, it can be adapted. I'm pretty sure that Dr. Bellamy and Dr. Jordan will publish soon protocols in terms of how to do the Imani U. And just as an even clarification, Imani has different stages. And when I think about protocol is in the project that I work, which is people do the therapy, the group therapy in Imani at churches, but there's this new cohort which are randomized to Imani groups only, or MAT, meaning medications for addiction treatment. Some folks that are Imani are randomized to get addiction treatment. And how it works is that I'm here or in my house with the screen in front of me and the camera, and the folks that are randomized to MAT, they get to see me to discuss medications for addiction treatment. It could be for opioids, cocaine, alcohol. And all the treatment that I do is via telehealth. So it can be that they're in group and they have their appointment at 6:30 p.m. and the counselor say, hey, it's time for your appointment. They see me for 30 minutes and then they return to group. But I'm just clarifying that because there's different phases of Imani. There's the general approach, which is the providing the therapy at the churches with the counselors from the community. And the part that I have been involved is delivering MAT along with the Imani Breakthrough treatment that is already given. So the idea is to compare how is Imani MAT versus a regular clinic MAT. That's pretty much the bottom line of it.
And thank you for the answer and for all the questions. Perhaps we can put the name for people that are interested in this. I will look it up after the chat and make sure to supply the names of the PIs on that. So if people have specific questions or are looking for specific protocols, can respond to that.
Okay. Next question. What traditional holistic healing and other cultural views modalities were recommended to be incorporated into treatment of American Indians and Alaskan Natives in the study from Benner et al.? Okay, and as a summary, this was a study or an article that was published based on a one-day meeting of multiple stakeholders, NIDA providers, American Indian, Alaska Native providers, and participants and leaders, just to talk about MAT for opioid use disorder. And some of what it was recommended to be incorporated was first to have the members of the community involved in the designing and implementation and evaluation of anything that is done. Just that the people that were going to get the treatment are involved. Other things that I remember that it was noted is that they mentioned how in their own communities, when they do healing circles, they just sit in a circle and they kind of like commented on how perhaps in addiction treatment, they may have group therapy that is not shaped like that or does not include native language. So those are forms that can be incorporated. In addition, they wanted not to bring elements of their spirituality and culture to MAT approaches, but to the vice versa. They already have their own way of thinking about health, spirituality, and just bringing MAT to that versus like the other way around it. And that can be like thinking holistically. Usually when we think about MAT, it's only the biological aspect for the most part, symptomatology reduction. But what happens to the other parts of the body that is very important? It's not only the emotional, physical, but the spiritual. So not only providing MAT, but making sure that there's adjunct treatment that would manage the spiritual part of the person, the emotional part, making sure that it's not the medication, that's about it. Also, there were comments that some folks, and I have seen this in other cultures, not other Native communities, perhaps naltrexone, which is an opioid antagonist, might be seen more favorable compared to methadone and Suboxone because it doesn't create like a dependence. And that might be an option. I will say that my first day at the Imani Breakthrough Project, which is mainly Latinas, Hispanic only, we had a Q&A session with the participants. And most of the questions were, what is naltrexone? Can you become addicted to it? Can I get addicted to Suboxone? And I quickly saw that many of the question was how Suboxone and methadone is quite different from naltrexone because you cannot get physically dependent on naltrexone. And if someone wants naltrexone, great. I just want to make sure they understand as well and have a lot of education, and they recommend this as well, having communication with stakeholders, even tribal leaders as well as providers that are in the community, like how different is Suboxone and methadone from a street drug. Also, those are some of the things that come quickly to my mind. I think one of the part that stuck up with me more was being able to treat the person in their physical aspect, emotional aspect, spiritual aspect, very holistically, like medication focusing only on the symptoms, the withdrawal, the cravings, but making sure that you had adjunct for the other aspect. And this is also applicable to other cultures. Like the way their leaders think about treatment might influence if others will get treatment as well. So making sure that community leaders are involved in the talk and have buy-ins. Are you seeing any successes in narrowing the gap in treatment with racial and ethnic minoritized communities? Ooh, it's a big one. There's progress, but we need to do a lot more, a lot more. And when I say there's progress is that the Imani Breakthrough Project, that did not exist 10 years ago. There are many other people in other states that want to replicate that. That's an example of progress. Banners and others working with Native communities, that's progress. I will say, to give an example of another clinic that I think is helping with doing interventions that are different and help move people forward is the outpatient consultation clinic that we have in this building. So this building, there are many psychiatric teams, ACT teams, psychosis teams, a STEP clinic, Hispanic clinic, which is psychiatric treatment only for Hispanic folks. But we have an outpatient addiction consultation. So psychiatrists can refer to us. We see them only for the addiction. We try to stabilize the most that we can and then refer back. That's quite unique. And most of our community here are Black and Latinx and whites too. But we have a big representation of a big proportion of people that are Black. So that's an example of how you can implement something here that will work for the people. And why that clinic was done. So we have this clinic, CMHC. The satellite clinic that does addiction is outside of CMHC. You need to take a bus. You need to drive to get there. And when people were referring folks to get addiction treatment to that other clinic, they were not getting there. They were not showing up. So the idea is we need to do something. People are not getting to the other clinic. And we're just having that clinic embedded here to help with more access. So bottom line, there is progress, more is needed. And I think one of the main reasons why progress is occurring is because of who is doing the research as well and who we're taking to key roles. Like Dr. Ajana Jordan, who is the PI at the Imani project, she also did the REACH program, which is to basically have expertise training on culture responsive intervention and addiction treatment for minoritized trainees and psychiatrists. I was part of that group. And to be honest, it was very refreshing to have this cohort that looked like the flip side of a classroom, mostly Black folks, Latina, Native, and one or two white folks. I'm not saying that's the solution, but I have seen how the people that are part of REACH, because of REACH giving us many opportunities and extra knowledge, being able to do more research, do more work. On a personal level, I didn't come from a family that had doctors and things like that. When I went to medical school, I truly struggled to understand like how people get to programs, how people present, how people publish things, because I had no idea. And I quickly learned that networking was important, but I still don't understand who you need to network to get opportunities. And for example, when I got to the REACH program, they sent emails with opportunity like, oh, you can submit to this. Oh, you can apply to this scholarship. It's like they were putting opportunities to you in emails every month. And I was able to get that knowledge and that access to opportunities because it was curated for us. So making it easier for you to continue being nurtured to do more for the communities that you want to work with. Next question. Which drug policies do you feel are most harmful to the racial minority communities? And in a perfect world, what changes need to be made to better serve racially minority communities? How do you think we can move toward this perfect world in terms of identifying the right people or organization to successfully impact policy? It's an important question, big question. I think there's not only one policy that is to blame, it's multiple policies and the effect of those in a domino effect. Of course, with the war on drugs 1970, I think that really set the tone, not only in policy, but what we were seeing in the media about who was to blame for specific addictions. I can think of when you look at historical data of pregnant patients that use cocaine versus pregnant patients that use opioids and how that was represented. So I think the war on drugs really separated who is affected by what. And we can also see that and how it affected in incarceration rates for some groups, as we discussed. So what we can do to move forward? That's a hard question and very important one. So we all need to do the work. We all have different roles. It's not that all of us need to be advocates, but we need to say something when we're doing something and we see something. In addition to that, I think one of the main things is that we need to make sure that we evaluate what we're doing in terms of program implementation. Good intention is not enough, as I mentioned last week. Again, good intention is not enough. We all have our blind sides. And I think programs need just to make sure they know who are they treating, who are they missing, and what can be done. So critical evaluation, it can be every 6 months or annually, having mock patients to see how the clinic is going, I think is truly important. And the last thing I will say, and how it's tied up with policy, I have like this analogy that I use a lot my laptop. Like my laptop is like something that I use a lot, but what my laptop will be if I don't have Wi-Fi. I think if I don't have internet, I will not do much with my laptop, say with my cell phone. If my cell phone will not have data and I would do only calls and texts, I will use it much less. So when we think about intervention, harm reduction, how we can move forward, there needs to be interventions, but policy that will also be make it make sense. I can think about Portland and news in the last years and how like what they have been doing in terms of the criminalizing drug and a lot of media about that not working out. And who knows, we will see in a couple of years how things turn out for that. But there was supposed to be a lot of money going to have case managers, intervention. And for the last couple of years, although that money was going to be present, it didn't turn out to be as present. But the decriminalization happened. So they did not happen at the same time. So again, I think about the metaphor of having the analogy of having an electronic device without Wi-Fi. How helpful would it be?
Potentially, while someone else is thinking of a question, I did have one other question, because we've talked some about finding ways to make adaptations to evidence-based interventions that are already present. And I'm just curious of what recommendations you would have for someone who does want to find a way to make a cultural adaptation for a specific group, kind of what that process may look like, or how you could go about finding resources that are already out there that may have already done some cultural adaptation.
Yes. So I like what you mentioned at the last moment about potentially someone doing the work already, and you can like not reinvent the wheel and go from their experiences, right? I think about my work with Latinx folks, and again, making sure something as simple as thinking about how to explain something that can be understood by a particular population. Like for Hispanic folks here mainly are first and second generation. They use a lot of dichos, proverbs, and just something as simple as having a unique proverb that you can use to explain addiction. Like I usually tell folks and have a picture of a green area in a valley, and I kind of explain addiction using that picture. Like I tell them, imagine that you're in this green area and you walk from one tree to another every single day. What will happen to that path? And they will usually say, well, the grass will stop growing. Yeah. And if you want that grass to grow again, do you think, well, what you need to do? Well, I just need to take another path, or I don't know. So I guide them. So you need to stop walking the same path. But if you stop walking, the grass will grow in one day, 1 week. No, like months. So it's just being able to use an example and say, well, addiction is similarly in the sense that if you use one day, it's not meaning that you will get quote unquote addicted. It's that people need to use every single day for a long time to have and build a substance use disorder. And if people stop one day, doesn't mean that it will be full recovery. It needs time for your brain to heal. So we need to expect that it's not like a paper cut that you heal in 2 days, or a torn muscle that you might heal in 3 weeks. It's like a broken bone and you need months. So that helps them many times feel less guilt, because they feel a lot of guilt of not being able to have control right quickly of their addiction. But that's just one example of things that we have in our toolkits to explain things to a specific group because it has worked. But we know that dichos or proverbs tend to work best for first generation, second generation. The fourth generation, fifth generation understand this as well, but it's more relevant to younger generation. So with all that said, as you can see, there was a knowledge already in place of differences between first generation, second generations to other generations, knowing the cultural construct that was important, dichos, for example, for Latinx or Latinas, and the specific example that we have used with a lot of people and they seem to understand well. That's just one example, but it takes having people from the same cultural background and others who are willing to learn a lot to take the time to think about these things and have it for the toolkit of all staff members for the clinic.